I know it's lunchtime. Everybody is getting up for lunch. So I request my co-chairs, Dr. Suma Ganesh and Dr. Radhika to join me, please. So our session is about how to approach a child with acute acquired vision problem with complaints from all our specialities, cornea, the retina, orbit, all our specialities are covered. Let us start with Dr. Suma Ganesh. Dr. Rohit Saxena will come little late. So my Dr. Suma Ganesh from Shroff Eye Hospital, Delhi. Dr. Radhika from Arvind Eye Hospital. Over to Dr. Suma Ganesh. Acute acquired non-accommodative esotropia in children, which has become more common after COVID period, and now we do see them more often than earlier. Over to Dr. Suma.
Thank you, Dr. Laila, for giving me this opportunity. And I would like to speak on ANET in children. As ma'am said that it's increasing now. So acute acquired non-accommodative esotropia in children is a disorder of ocular alignment, which is characterized by non-accommodative esodiviation. And it develops it's not seen in childhood, it develops after 6 months of age. It is an otherwise healthy child. So it is occurring infrequently, but often raises concerns for the potential of an underlying neurological malignancy. So in a 10-year cohort study done by Mohani found that ANET is to be the third most common after accommodative esotropia and intermittent exotropia. So we have children with sudden onset esotropia and diplopia. Comitant, the angle of deviation is equal in all directions of gaze, and diplopia is a common and normal ocular eye movements. But remember, this does not rule out serious underlying neurological problems. So we have the types. We have the Swan type. So you have occluded it following monoocular occlusion. Suddenly there is a disruption of binocular fusion, and suddenly the child presents with acute esotropia. You have the Burian-Franceschi type. It's around 30%. It starts between 8 months and 3 years, and there's also late start between 3 years and 8 years. They will present with acute diplopia, minimal refractive error, and they have good fusion. But mostly they are associated with some sort of psychological stress. Large deviation, but small refractive error. The third type is Belchowski type, 36.6%. This is esotropia which occurs in adolescents and adults with varying degrees of myopia. And it shows equal deviation and distance and near. So basically it is uncorrected myopia, excessive near work leading to tension in the medial rectus and thus causing esotropia. Now, one variety is the type 4, which is associated with high hypermetropia that can be controlled with refractive error correction, and a type 5 where it can be associated with intracranial pathology. So if you have more than 2.5 years child, mostly second and third decade, diplopia, divergent insufficiency, you see nystagmus, A pattern, kindly do an MRI. Okay? So the clinical features of neurological AACs, mainly if they have hydrocephalus, you can have. There will be an infantile ET with an A pattern, and there will be a nystagmus and abduction. So you have a large angle ET, and you have divergence paresis. So if it's Chiari, this is an emergency because this needs to be referred to a neurologist very soon. It presents in early adulthood. You'll have ataxia, dysarthria, dysphagia, and divergence paralysis and downbeating nystagmus. Brain tumor you can again have, but in this case there will be a V pattern, and in contrast you may also see it associated with the 6th nerve paresis. A thalamic lesion, you'll have meiosis, and due to disturbance with the versions and fusional mechanism. So clinical history is very important. Time of onset, if there was any history of any physical or emotional stress, patching, any neurological illness, duration of near work, and history of preceding events. The management is refractive correction. If nystagmus, poor fusional potential, please proceed for an MRI, prisms or Botox injection, and surgical. So let us go cases. So this child presented with sudden diplopia and comitant esotropia in a child who had straight eyes, and we did a cycloplegic refraction, no refractive error, got an MRI done normal, so it is basically a decompensated esophoria. So in this case, it's simple. You do both eyes medial rectus recession, but wait for 3-4 months. Do not jump to surgery, and especially in a case of acute comitant esotropia. You have a child with diplopia, so you're not losing anything. But wait for some 3-4 months before you plan a surgery. So in that phase, you can, if there's a mild refractive error, you can give a refractive error correction or prisms. So the surgeries for these cases are very good with having good motor and sensory outcomes. So we'll have full restoration of pseudoacuity and resolution of diplopia. So now you have another case, excessive phone use during the COVID, and this has caused sudden onset of inward deviation since 1 year. And for this case also you do a both eyes medial rectus recession. Now this child presented, is a 7-year-old, presented with a sudden onset of deviation. His visual acuity was 612. Got an atropine refraction done. There was a plus 6.5 in both eyes, gave him glasses. But even with the glasses, he had 50 PD for distance and near, and he had diplopia, which was corrected with the, so I gave him Fresnel prisms. Put on Fresnel prisms, so this is the Fresnel prisms, where here you have Fresnel prism put in his eye, and for 2 months, and then operated, and then when he followed up in the visits, operated for the adapted angle. Suppose now your ESO increases, then you again have to change your Fresnel prisms. You may have to increase the Fresnel prisms and put another Fresnel prisms. So till the adapted angle, till we get the adapted angle is how much of esotropia is there to correct his diplopia. Till then you will keep the Fresnel prisms and then you will operate. And these children normally have good results. So case 4, this is a myopia with a -1 with a -0.75, 60 PD. The brain was normal, MRI brain was normal, and we did a 3 muscle surgery. So you see the variable cases. So now this girl presented, it was a 9-year-old girl who presented with sudden inward deviation of eyes, blurring of vision for distance and near. There was vertigo, binocular diplopia since 1 month. Her school got changed, and so therefore she was not comfortable with the new school, missing her old friends. So she was not on any medications and there was no history of trauma. Her visual acuity was 636 in both eyes, unaided N24. Pupil was normal, equal in size, brisk and equal reaction to light. There was a large comitant alternate esotropia, but it was variable, 35 to 80 prism diopters at distance and near. There were normal ductions. When we did a retinoscopy, the myopia was variable up to -4 to -5. Did a dynamic retinoscopy, there was a lead of -4. So what next step? Atropine refraction. So in atropine refraction, we found that the vision was still 624. Retinoscopy was only 1 + 1 cylinder with 90-degree axis. So it's a pseudomyopia. And the cover test still showed alternating esotropia and diplopia with no reduction in amplitude. Got an MRI done at normal, because even in these cases, you can have a neurological problem. And we diagnose this as accommodative spasm or spasm of near reflex, where you have excessive convergence with esotropia, pupillary miosis, ocular pain, photophobia-induced pseudomyopia, which disappeared with cycloplegic. We advised atropine 1% twice a day for a month, gave her bifocals because of the atropine. And then again after 1 month, for 2 months we gave her atropine, and we seen that there was no improvement. It was still 624 vision, N24. Of course the retinoscopy was +190, but there was still an esotropia of 60 prism diopters. So the next step was to give Fresnels. So we gave her Fresnel prisms, and because the long term we found that we could not keep on giving an atropine, so we gave her Fresnel prisms, and then we referred her to the binocular vision therapy clinic. We have a very good binocular vision therapy clinic at Shroff, and we gradually, so they advised accommodation relaxation exercises, fusional vergence therapy with prisms. So we did around with Brockstring and single aperture rule. So this was done, and it was done with the prisms, and gradually we tapered off prisms and bifocal glasses. So what we found after 40 sessions was the child improved with 6/9 vision, and it was ortho. There was some esophoria with good control, and we found that the stereopsia also improved with 40 seconds of arc. Then we slowly removed her bifocals and prisms, and we also gave relaxation and fusional vergence therapy. So to conclude, it can be a varied etiology ranging from convergent spasm to those harboring serious intracranial diseases. So it is important for us to diagnose these conditions. So ACCE has a small but significant association with intracranial disorders. We also have to rule out that the possibility of an underlying intracranial disease should be kept in mind, especially in children presenting with acute comitant esotropia, because sometimes they may have an accommodative component, but we find there may be no neurological signs, but we still find they may have there may be some neurological disease. So we need to do neuroimaging, and we need a complete ophthalmological and neurological examination. So we can also rule out cyclic esotropia if it is cyclic, and myasthenia also, which can be also present. Thank you.
Thank you, Dr. Suma, for that wonderful talk. Do you do prism adaptation for every case with the ANET before you take up for
Yes.
surgery?
Most of the yes.
Or all isotropes?
Because what happens is that, so now if they're not improving, so now you have done an atropine refraction, and then you found that there is no refractive error, then I do give prisms. So not for just for prism adaptation, but a Fresnel prism just to know what is the adapted angle for with the diplopia is getting corrected. And I also do not want to operate just at 1, 2 or 3 months. It is better to wait for 3, 4 months in acute comitant esotropia. So prisms is helpful. So when once you give the prisms, then the child comes back, and then sometimes you find that the ESO has again increased. So at least it tells you that what adapted angle which you operate. Because if it increases, then again you'll have to give another Fresnels. At least your surgical outcome will be more than 90%.
And what about the role of Botox in the early stages? When
Yeah,
they
there
come
are
back?
papers, but I'm not giving Botox. But there are papers for Botox. I think it will be helpful. There's no, I don't think it should be a contraindication. It can be given. Botox can be given if you find that if the child is cooperative, or I mean, suppose in an adulthood, like in 12, 13 years, you can give Botox.
Any questions from the audience? So shall we move on to the?
You said it is for children. If esotropia is there, they are presenting with
Mic is
diplopia.
not working, I think.
But if any adult around 18, 22, they
Yeah.
are coming, and they are still complaining of diplopia even after prism adaptation test. So what to do? Fresnels, and how much time actually will be waiting, or how frequently we are supposed to see them before going for surgery?
Yeah, so suppose now it's an adult, like mostly this Belchowski type, they're mainly adult patients, like myopia with esotropia. So you give Fresnels. If you find that with the Fresnels it is not becoming, the diplopia is still not, then maybe in those cases you can do a trial of Botox and then go for the final surgery. Or because it should fuse, why should it not fuse? Because these are good outcome cases. And so it should fuse with Fresnels. So if say about after 3, but if what happens is that sometimes in PAT, the esotropia, they're eaten up. You get more and more esotropia every time when the patient comes. So you wait, you give them, if they can afford, of course, because Fresnels also expensive. But I think you should give another Fresnels and tell them to come with a new Fresnels. Suppose if it's 50 and you have gotten your next visit 60, if they can afford, then you can give another prisms and again call them after 1 or 2 months. If they can't, go in for a 60 prism surgery.
So how much actually time, okay, it has become stable, so how long should
Yeah,
you
4 to
wait?
5 months I operate. After 4 to 5 months, because it's not practical for the children, for the patient to carry on life with diplopia. And
Do they come back
yeah.
Yeah. Thank you, Dr. Suma. So next, most of these children, they don't complain much, so that is the importance. There is a big lack of clarity in visual complaints. So let us move on to the uveitic visual loss in children, which is a vast topic, I know. Over to Dr. Radhika Tundikandi.
Okay, good afternoon. Thanks for being here during lunchtime. So uveitic causes of visual loss in children. Uveitis is a potentially blinding disease. Why? Because children usually do not complain, and the signs and symptoms of the uveitis in children are very subtle. and even the parents don't recognize it. And when they come to us, they usually come to us quite late, and because of the severe complications of the disease. So I have just roughly classified the uveitic causes into non-infectious and infectious causes. JIA, or juvenile idiopathic arthritis, still remains the most common cause of non-infectious uveitis in children. In infectious causes, we have toxoplasma as the commonest cause worldwide, but in an endemic country like India, ocular TB is also equally important. So let's move on to juvenile idiopathic arthritis. I'll dwell on this a little bit longer because it's quite common in children, and it causes non-granulomatous anterior uveitis. It can be unilateral or bilateral, and if it is bilateral, it is usually bilaterally asymmetrical. The joints involved are usually the large joints, the knees and the ankle can be involved, and they usually come to us with these complications like BSK or secondary glaucoma, cataract, and sometimes if the inflammation is not well controlled, they can have intractable cystoid macular edema, hypotony because of ciliary body atrophy, ciliary body detachment, and cyclitic membrane formation. Okay? So we need guidelines for uveitis. So high-risk patients are those who are ANA positive, who have onset of arthritis at below 6 years of age, and who have less than 4 months, 4 joints involved. And so these patients need to be followed up every 3 months. Moderate risk patients who are ANA negative can be followed up every 6 months. Then you have low risk patients where they have arthritis with systemic involvement like fever, hepatosplenomegaly, malaise. So treatment guidelines, you need to just, because it's an anterior uveitis, treat them with topical steroids, continue it for at least 3 months. If they do not respond, add steroids and immunosuppressive. Again, if the response is poor, add biologicals. If you're going for surgery, ensure 3 months of complete quiescence before you go for surgery. And you need to follow up the patient very frequently, even after surgery, for inflammation. Continue medical therapy till 2 years of quiescence. This is another syndrome, Blow syndrome, which again presents with arthritis and uveitis, but it's different from JIA because it's usually granulomatous. And here the small joints are involved, and you have severe deformity of the joints. And the ocular cause, it can cause present as anterior uveitis, panuveitis, and even have present with corneal scars. The cause of poor visual outcome in these patients is secondary glaucoma, even hypotony because of cyclitic membrane formation. So they need aggressive treatment with steroids and immunosuppressives. VKH can also occur in childhood. We had this 11-year-old boy who presented with defective vision in both eyes. You can see the hyperemic disc and the serous detachments in the fundus as well as the OCT. And he was treated with steroids and immunosuppressive, but he needed adalimumab injection for complete resolution. In VKH, you need to follow up the patients very carefully for chronic CME, subretinal fibrosis, CNVM, which can cause poor visual outcome. Behçet's disease is a systemic vasculitis, but it can cause vasculitis in the eye as well. But this 15-year-old patient presented to us with floaters, and she had history of oral ulcers. Even though the fundus was clinically normal, but when we did an FFA, we found the characteristic fern pattern capillary leak. And these patients with Behçet's lose their vision because of vasculitis and optic atrophy, peripheral vascular NVE formation, vitreous hemorrhage, and retinal detachments. Pars planitis is an idiopathic subset of intermediate uveitis, can present with snowballs, snow banking. Anterior segment is usually quiet, just a few spillover cells. Cause of vision drop is usually intractable CME, and sometimes the peripheral vasculitis may be there, which can result in a new vessel formation and retinal detachment, vitreous hemorrhage as a cause for poor vision. Do not forget the masquerades, because by diagnosing a masquerade early, you can save the eye as well as the life of the patient. So we had this patient who was on treatment for acute lymphoblastic leukemia, and he presented to us with a hypopyon, and we did an AC tap, and it showed malignant cells. And patient chemotherapy was intensified, and it saw after local therapy the hypopyon resolved. So let's move on now to the infectious causes. Toxoplasmosis, as you know, is the commonest cause of infectious posterior uveitis. It can be congenital or acquired. Congenital toxoplasmosis occurs when the mother has an active infection during pregnancy. So child can be born with telltale signs of systemic toxoplasmosis, or the child may look normal, or the child may have a macular lesion like this. You can also have the acquired toxoplasmosis in children, like in this child who came with a retinochoroiditis patch near the macula. You can see the adjacent scar and the Chiarides arteritis. So on recovery of the infection, the child will have definitely a scar, but active treatment can reduce the size of the scar. Toxo lesions can also be seen peripherally, which usually they heal without sequelae. Sometimes there can be visual loss, can be because of a macular drag. Other causes of poor vision in patients with toxo are CNVM and retinal detachment. Toxocara is a nematode worm which is found in dogs, and it can cause posterior pole granuloma. It can cause a peripheral granuloma with traction bands extending from the granuloma to the disc as well as the macula. And when it heals with sequelae like vitreous membranes and opaque vitreous, which is also responsible for the poor vision in such patients. Active lesions like this can be treated with albendazole as well as oral steroids, but most of them may require surgery to remove the ERM or the vitreous opacities and for the retinal detachment. DUSN is usually unilateral. If they come to us early, this is the ocular picture with hyperemic disc and track lesions. So your course of albendazole with steroids can cure the disease. But in case they do come to us late, this would be the clinical picture in the eye with optic atrophy and thinning of the inner and outer retinal layers. Even though mumps is a benign condition, of late we have been seeing patients with who develop defective vision in both eyes, poor vision in both eyes after an episode of mumps. So this is a case of cerebriform retinitis post-mumps. It caused complete necrosis of the inner and outer retinal layer. We were able to salvage some amount of vision in this patient with steroids and hyperbaric oxygen therapy. Trematode is a larva which is found in the waters of certain rivers, especially the Kaveri River, and children swimming in these waters get the infection through direct infection of the conjunctiva by the larva. So it can cause granulomas in the conjunctiva. It can cause an AC granuloma. Usually the outcome is good with steroids, but some of them do, if you don't diagnose it early, can cause retrocorneal membrane and a complicated cataract. Now don't forget ocular tuberculosis in an endemic country like ours. So this patient had a choroiditis lesion very close to the macula. You can see the vasculitis as well, and her MANTO was positive. Her CT chest showed evidence of old TB. And you can see the OCT showing an RP elevation in the contact sign. And after starting ATT, there was complete resolution of the lesion. So early recognition and timely management of the disease and its complications can preserve vision in a child. Thank you.
Thank you, Dr. Radhika. That was an excellent presentation. I have one question. Is like when we operate for cataract, pediatric cataract in JRAs with, we put an intraocular lens, and then we find that the inflammation, there's so much recurrence of inflammation even after 1 year. So how long do we have to give the immunosuppressive therapy? Because I find the uveitic specialists keeping on giving the immunosuppressive therapy, and sometimes it is for 3 years or 4 years.
Yes.
So
they have to be continued for a very long time, ma'am. Even we need to have 2 years of quiescence, as I mentioned in my talk, 2 years of quiescence before you can even think of stopping the medications. So, and soon after a cataract surgery, patients can develop inflammation off and on. Therefore, they have to be followed up very carefully, even in the post-op period. And you do not stop the immunosuppressive or the corticosteroids prior to surgery. You just continue it.
So the parents keep asking, when will it stop? So it won't stop.
It won't stop till the child achieves 2 years of quiescence. Yeah, you will have to convey that message to them.
Okay. So thank you, ma'am. So we will call on to stage the next speaker, Dr. Rohit Saxena. Is it ready? Yeah. So he'll be speaking on challenges in managing optic neuritis in children. I don't think he needs any introduction. He's from All India Institute, RP Center, Delhi.
Thank you.
The president of Delhi Ophthalmic Society.
Thank you, Suma, for the introduction. Thank you, ma'am, for the opportunity to be here. And I'll be talking about optic neuritis. There are a few subtle differences in a child as compared to an adult, but the initial part of my talk will be generally trying to understand optic neuritis. And of course, the other spectrum that we are now beginning to see and hopefully try to understand. I do not have any conflict of interest. So the challenges are, particularly when it comes to a child, whether there is actual true visual loss or not, whether it is optic neuritis or not, then what is the potential etiology, which we can try and see whether it's typical or atypical, what are the key investigations to be done, and finally, what is the management options. So optic neuritis is inflammation of the optic nerve. Again, remember the definition when we are talking about. Now we move towards inflammation of the optic nerve. The typical clinical features in a normally defined typical optic neuritis would be in 20 to 50 years. So it's young adults who are affected. So the moment we talk about a child, we are in the realm of what has been described or clinically perceived as typical. So usually typical would be uniocular, would be in older patients, not the children that we are talking about, usually associated with painful loss of vision over hours. The pain is not severe, it's generally associated with eye movements. The vision loss can be subtle to complete. In a child, the challenge becomes one, assessing the actual vision loss, and also that the duration of vision loss, because children may not come to you with only single eye involvement. So many of them would miss one eye involvement, and therefore you are not sure what is the duration of the vision loss that the child may be having. Conventionally, typically the patient's vision loss would worsen to maximum about 2 to 3 months, a week, settle down, kind of level off and then start improving. The presence of an RAPD in a unilateral case, in fact, that's one of the major signs that you're picking up, particularly in a child where you are not able to pick up the visual acuity, and of course the fundus appearance. Now the atypicality comes obviously the moment we are looking at an age group which is outside what is conventionally described for typical. The vision loss is very sudden. There is either absolutely no pain or very severe pain. Older patients, bilateral involvement, so there is obviously an overlap or confusion if you're looking at ischemic or not. Severe disc edemas, disc hemorrhages, progression of vision loss which continues, or there is no treatment even on, no improvement even on treatment, and recurrent. Now recurrent optic neuritis is not so uncommon in a child, but essentially will still continue to be classified as atypical when you are describing or discussing optic neuritis. The importance of defining this, or the importance of separating these two into typical and atypical, is more now to do with the etiology than anything else. We know that most likely, again there are no rules, most likely a typical presentation may be demyelinating or idiopathic isolated. So that is one group you're looking at, and that's the concentration you're doing at. So the child you're looking at, it may be just isolated idiopathic, you treat and he probably will never come back to you again, or right at this moment we are seeing some signs or features of multiple sclerosis, and or they may develop over time with recurrence or as the child gets older. Atypical, on the other hand, has a completely different etiology. Now, it does not mean that atypical presentation may not be seen in multiple sclerosis or even idiopathic, but the likelihood of it being because of many of the other causes is something that we need to look at. Most importantly, for a child, it can be post an infection or vaccination. So adequate number of cases have been reported after a vaccination also, and of course post infection. So they may have just a small URI, they may have just a small low grade fever, and they come to us with a vision loss. The diagnosis essentially remains clinical, and in a child we know that it can be challenging, particularly trying to accurately measure visual acuity, what to talk of looking at other visual functions like color, contrast and fields. But these are essential to be able to get a baseline and see how the patient is moving and trying to understand the clinical profile of the disease. In a child VER, again, you can aim to get a pattern VER, but sometimes you just have to make do with a flash. Flash is not that useful and doesn't convey as much, but in the absence of a child fixing for long on the pattern, you would have to do with that. And again, OCT is just more or less for understanding rather than truly diagnostic at the moment, although there are differences in MOG and optic neuritis, subtle features difference in OCT. The sea change, or the major change that has come out in the recent few years, besides of course the blood markers that we'll talk about, is the role of MRI. Even earlier, MRI was important and was considered helpful in understanding the progression to multiple sclerosis, but I would say now it's almost mandatory. In fact, mandatory unless of course you have major financial issues which limit. There is no role of a CT scan. If you're suspecting multiple sclerosis, it's as simple as to write an MS protocol, but essentially implying that it's an MRI brain in orbits with contrast, with fat suppression for the orbits and flare for the brain. Of course, the moment you write MS protocol, hopefully the radiologist will understand. Spine only if there are history of limb weaknesses or a suspicion that the patient may have NMO. The MRI features itself start giving us an idea as to what the etiology may be or what the cause may be. So MRI features are different. For multiple sclerosis, what we are classically taught with that there would be small segment involvement of the optic nerve that is affected, and sometimes of the other eye also. You may have the Dawson finger, so periventricular lesions that are there perpendicular to the ventricles. So these are classical features. But the moment you have atypicality in this, like long segment involvement, like you see in NMO going right up to the chiasma, or bilateral involvement of long segments anterior part of the optic nerve in MOG. So these are important differences, and at the very onset, you start getting an idea that you may be dealing with a particular form. So as I mentioned, not only is the MRI changes different, the clinical presentation as we talked. So atypical presentations, MRI showing us a suggestion as to which side we are looking at, multiple sclerosis, NMO or MOG, and that is the way we can start moving on in these children, because as I mentioned, sometimes it's difficult to get detailed understanding of the visual presentations. Optic neuritis treatment trial gave us IVMP as the role model for interventions, and that remains the standard of care, at least definitely as our first line. You are suspecting optic neuritis, multiple sclerosis related. Your first line intervention was IV methylprednisolone with a short oral taper, and then you follow up the child. There is a role of disease-modifying agents in recurrent optic neuritis. In a child, you hope that it may be related to a mild inflammation or infection, and may let it go at that and follow up the patient to see for whether long-term disease-modifying agents are required or not. In an older patient, you need to actually discuss and be proactive, see the magnitude or the amount of MRI lesions that are there and the risk factors for future development of multiple sclerosis when you want to discuss the role of disease-modifying agents along with the neurologist. The NMO spectrum disorder is now something that we are increasingly understanding, especially now with the availability of the biomarker, and that has shown that there is a much higher prevalence of NMO in India and in Asia per se. In fact, in the early part of this century, when we were discussing optic neuritis in Asia and India, we would always say it is looking a little different from what ONTT has talked about. And possibly we were looking at a lot more NMO rather than a pure MS and optic neuritis. So a whole lot of different presentation is there for NMO, particularly presenting like atypical. Again, we are increasingly seeing NMO and MOG more likely in a child, but even NMO is now being seen. Acute attack of NMO, whether it's seropositive or not, is managed by high-dose methylprednisolone, the way you would start. You're waiting for the blood sample report to come. If it is positive, you would continue your oral steroids for a much longer period of time. In fact, your IVMP may continue for 5 days or more. You will continue oral steroids for a long period of time, and if the vision doesn't recover, you may think of doing a plasma exchange therapy or a PLEX. So our interventions are different. Remember, disease-modifying agents are contraindicated in these patients. You may, after a long-term therapy of steroid, may have to switch with immunosuppressives like methotrexate in the long term rather than disease-modifying agents. It's important to early identify NMO and MOG because long-term prognosis does get affected by the delay in intervention. MOG is again another antibody that is being increasingly picked up, more common in children, more chances of recurrences in these patients. Fortunately, they do well by IV methylprednisolone in the first intervention that you have, but unfortunately, they keep getting recurrences, causing continuous and multiple attacks on the optic nerve, causing functional deterioration, and over long term, you may have a significant visual loss in these patients. So a patient of optic neuritis, typical, investigate, IV methylprednisolone, improves, follow up. No significant improvement or deteriorates or there is steroid dependence, it itself becomes an atypical feature. Revisit the child, and of course, long-term management will depend upon the clinical profile like MRI changes and the blood reports. We have an increasing treatment option. A lot of them fall in the realm of the neurologist, so your intervention has to be in association with the neurologist and discuss the long-term therapy based on the diagnosis that we have. And these children require a very, very long-term follow-up because they may develop these diseases over the long term. This is a very complicated kind of a map that we had made. This is published in IGO and is available open access. So this is just a broad overview, kind of repeating what I have said. It's important to get your diagnosis correct in the initial period so that you can intervene appropriately, more aggressively if you have NMO or MOG, and moderately so if you have you have optic neuritis due to MS. So identify biomarkers. Baseline MRI is now essential. Your clinical features may overlap between a lot of these, so you need to be careful, and investigations is now the key. And because they are different entities, their management is different, so be sure what your diagnosis is as you plan your management. Thank you very much for the opportunity.
Thank you, Rohit, for the presentation. Any questions from the audience? I'm sure there'll be a lot of questions.
Ken, do you see patients with tuberculous optic neuritis in your practice?
So now that's a little difficult diagnosis to make. So two ways you're looking at it. Either you're looking at tuberculosis as the primary cause, so you're looking at lesions, or you're looking at infection, inflammation around the optic nerve related to a possible tubercular pathology. The other group is that tuberculosis is there in the patient, and I'm not very sure whether it may not be directly infective, but we believe it may be because of some of the toxins that are being produced. I would say we do not see any significant number of patients who are directly due to tuberculosis, but unfortunately we see a lot of patients related to the interventions that we're giving, particularly thiambutal. So currently I would say if I have a patient with a perioptic nerve head lesion, a choroidal lesion, I would suspect tuberculosis because that is maybe a tubercular lesion, which is a juxtapapillary lesion. So that is a possible presentation of tubercular optic neuritis. But as a lesion elsewhere and remotely causing optic neuritis, I don't think there is enough evidence for us to be able to correlate that closely.
In adults, we do see TB optic neuritis. They present, as you said, with the disc granuloma, which later on heals with a peripapillary scarring.
Absolutely.
And there you will find even tuberculous lesions, like small choroidal lesions elsewhere in the fundus,
Right.
which heal with scarring along the vessels. So
Absolutely, yeah. That is a group that one would see. And as you said, I mean, you see a lesion that is not typically looking like the disc edema that you would see. It's a fuller edema. You'll see some choroidal changes, juxtapapillary, and that sets you off thinking that it may be infective.
Okay. Thank you, sir.
Madhvi had a question.
Rohit, you said that we generally do not use monoclonal antibodies in these type of cases. But there have been some studies on the use of rituximab in these to prevent the relapse or recurring cases of NMOSD. And the results have been somewhat promising in the initial stage. I do not know what the third clinical trial final results are there, but that have been used and has been recommended. Am I right, Rohit?
So there is very good evidence for adults. Rituximab has been used for preventing relapses in adults. For children, it's still not clearly established. So as I mentioned, at least in the Indian setting, a lot of these children may not come back with relapses or have such a long term. But yes, the moment you have a serum positive patient, your interventions change. If you have a seronegative for NMO and MOG and you think it's just a demyelinating lesion, you may in a child still be willing to follow up. But yes, the adult management is different, and that's why I didn't stress so much on the long-term management with immunosuppressives and immunomodulators.
Hello sir, thank you for the presentation. So my name is Dr. Madhvi. So I'm currently working at Sitapur Eye Hospital. We encountered a patient, a child with a 7-year-old child who had no previous history of any infection with bilateral vision of vision loss of till 6/60 in 2 weeks, and on MRI there was perineural enhancement. So in these patients, the child was not, the parents were not able to afford the serological investigation, any investigations. So we started with we gave the child steroid, the disease regressed, and when we tapered the steroid and stopped, it again recurred. And we had to again start a short course of steroid and taper it very slowly. So in such patient, how do we proceed when the patients are not able to go for serological investigations and they are presenting for a very poor socio-economic status, sir?
As you mentioned, the MRI was suggestive. So if you don't have, that's why the stress now on MRI. So MOG would tend to present with a long thickening of the nerve with particularly perineural sheath enhancement. So if you see that, that is fairly suggestive of a MOG, and you would then increase your steroid course and have a very slow taper, because in these patients, you are going to see recurrences, and possibly, again, we don't know in hindsight, some of those patients we used to label as cryon were probably those who were MOG. So that is why we know that they are kind of steroid sensitive but also steroid dependent. So your therapy may be long-term steroid, and if it again recurs after you stop or taper steroid, you may have to think in terms of shifting the patient onto an immunosuppressive treatment as a long-term measure.
Thank you, sir.
Now I would like to call on stage Dr. Laila Mohan. She's from Kerala, and she will be speaking on approach to a child with transient visual obscurations.
Thank you, Dr. Suma. So, transient obscurations of vision in a child, either positive, like flashes or scotoma, or negative, like graying or blackout or curtain-like loss lasting for few seconds or minutes or even hours, can occur in children, which is not uncommon. It may be due to ocular, orbital or intracranial causes, and children may not say whether it is a positive or negative phenomena is there, or whether there is a black or gray. They may just say it is a blurring of vision, and they may not also say whether it is monocular or binocular. And often the first evaluation may be normal, and history may be the only clue as to the diagnosis. And though the commonest cause of transient visual obscuration in children is migraine, we need to investigate for any other serious issues. So let us see some cases. This is a 7-year-old girl who was brought with history of blurring of vision. Thank you. At school, the previous day, which lasted for some time with no previous episodes of the same complaint. Headache was there after she came from school, but was not severe. There was a strong family history of migraine in the mother. Clinical findings, including visual acuity, pupillary reactions, and fields, were normal. Considering a strong possibility of migraine after a neurological consultation, which was normal, she is being followed up for further attacks or for further investigations to be done if necessary. So migraine is the commonest cause of an episodic visual obscuration. It's not uncommon in children. A family history is common. History is important of the duration of visual obscuration, and the associated symptoms are important. Headache of migraine starts about 30 minutes to 1 hour after aura, which may last for about 30 minutes. And from history, a thorough evaluation and a decision of further investigation should be done or not should be made. Sometimes children come with entoptic phenomena. During rubbing of eyes, phosphenes are seen also. So Visual aura of migraine, 30% of children come with visual aura. The scintillating scotoma, as you see in this picture, it may slowly develop, positive scotoma may enlarge to occupy the whole field in about 30 minutes, which is classic. And amaurosis fugax, or without headache, just visual loss, can also be there with blurring or holes of vision, holes in the visual field, or metamorphopsia, which is called Alice in Wonderland phenomena. And headache is not often the throbbing type as we see in adults. And synesthesia or other sensations along with that can occur, sound producing photophobias, auditory visual synesthesia. Sometimes functional MRI may show a positive stimulation in these areas, and ERG and EEG give inconsistent results due to the short duration of symptoms. And visual perception, entoptic phenomena are visual perceptions arising within the eye, and children are more conscious about these images which are seen. Phosphenes on rubbing eyes, sometimes even visual obscuration is seen due to severe rubbing of the eye. So next case is an 6-year-old girl who was brought with 3 episodes of visual loss of short duration lasting for a few minutes. There was a history of vomiting and tiredness following this. After complete evaluation for pupil disc edema and MRI, a neuroevaluation was done and EEG showed discharges in occipital areas, and a diagnosis of occipital lobe epilepsy was made, and she was put on anti-epileptics. It is ictal cortical blindness is rare to present vision loss in isolation in occipital lobe epilepsy, and is usually associated with some amount of loss of consciousness. It may be confused with migraine since it may be followed by headache. Blackout may last for hours, and interictal epileptiform activity is seen in the EEG. AV malformations of occipital lobe also can present similarly, so a thorough neuroevaluation with imaging is necessary when there is seizure. A 11-year-old boy presented with blurring of vision with few episodes of blackouts at school. On further questioning, he gave history of 2 episodes of headache also. Visual acuity was 6669 and showed some disc edema. Field showed bitemporal hemianopia. MRI showed a solid cystic mass pressing on the chiasma and was diagnosed as craniopharyngioma, and he had surgery. So transient grayouts or blackouts in disc edema can occur. Craniopharyngiomas constitute about 15% of the pediatric intracranial tumors, and blackouts may be the presenting feature of papilledema, especially in postural, as when stooping during playing or otherwise. Due to increased, it is due to the increased interstitial pressure producing hypoperfusion of the optic nerve head. So sometimes it may be elicited by a Valsalva's maneuver as well. A detailed fundus evaluation and MRI and neurological evaluation is essential. This 10-year-old girl presented with symptoms of blackouts during outdoor games at school. On further questioning, she had occasional headaches, mainly in the mornings. And vision was normal, pupils normal, fundus showed papilledema, and neurological evaluation in fields were normal. LP and MRI confirmed a diagnosis of idiopathic intracranial hypertension, and she was put on Diamox and is being followed up. So idiopathic intracranial hypertension is not uncommon in children. It's a diagnosis of exclusion, ruling out organic brain or vascular lesion or associated systemic pathology or even medications. There is a preponderance in girls, and after puberty, obesity is often seen. Medications like vitamin A, tetracycline derivatives, and recombinant growth hormone, lithium, ponatinib used in leukemia treatment, corticosteroids are the culprits. Tetracycline and vitamin A are supposed to impede CSF outflow at the arachnoid villi. So a history of medication is also important. A 9-year-old child with sudden blurring of vision when stooping forward, which lasted for a short time, with normal pupillary reactions and vision. Fundus showed blurring of disc margins and suspected papilledema. OCT and fundus autofluorescence ruled out papilledema, and drusen was diagnosed. HFA showed an enlarged blind spot. She was advised follow-up of fields and fundus. So some of the optic nerve disc problems like drusen can also produce visual obscurations like papilledema, as in papilledema. These can detect the drusen as a hyperreflective lesion, and fundus autofluorescence, OCT and ultrasonogram can diagnose them. When they are deep-seated, sometimes autofluorescence may not give the diagnosis. Disc coloboma, optic nerve sheath meningioma can also produce transient visual obscurations and need follow-up. They need follow-up. This child with occasional blurring of vision in left eye had normal vision and fundus, and left eye showed a fullness of lower lid with a scleral show. There was an elevation restriction and proptosis of 1.5 millimeter. A CT showed a heterogeneous mass lesion below the eyeball. There was on palpation, there was a firm mass felt below the globe. So orbital mass lesions like meningioma, orbital osteoma, fibrous dysplasia, all these can produce gaze-evoked visual transient vision loss, and sometimes undetected orbital fractures in children when they play. They may have also some entrapment of the tissues and produce a transient visual loss due to ischemia. This child, 15-year-old exam-going child, was brought with eye strain and defective vision. He was using myopia correction of -5, and unaided vision was 5/60. With correction, he had 6/6. NPC was 4 centimeter, and MEM retinoscopy showed a lead in accommodation. Cycloplegic refraction was +2, as Dr. Suma has already shown. He was asked to go off glasses, but without glasses he could not manage at all. For far or near. And considering his exams, we tried home-eyed, but accommodative spasms persisted. His mother was ready to go for atropine treatment, even though he was appearing for the 10th exams, because he was not able to study at all. So he was given atropine treatment, put off appearing for the exams. Counseling was done and weaned off atropine after a few months. So accommodation convergence dysfunction can sometimes produce transient visual disturbance for near and far. They may accept accommodation spasm. They may accept more and more myopic correction due to spurious myopia. Proper counseling and atropine followed by vision therapy is often needed to reduce the accommodative spasm. Vascular occlusion, though rare in children, can occur in cardiac problems, and there are some reports of transient vision loss. In smartphone use, what is called smartphone blindness, it occurs in the eye opposite to the dependent side when they sleep. It is said that dependent eye is dark adapted, and the light adapted eye, which is looking at the screen, becomes less sensitive. So when they look with both eyes, they see one eye is not seeing for some time till it gets adapted. So they should be advised against using of smartphones in the dark for a long time, especially when going to bed. So a systematic approach is necessary. Whenever necessary, we need to investigate for MRI, MR angio, Doppler may be needed. EEG may show interictal activity in seizures. Migraine is the commonest cause, but we have to look for other causes. Papilledema often produces blackouts, and neurological workup is mandatory in all these cases. Thank you.
The audience, thank you, ma'am. That was an excellent presentation. I think we do come across these cases, and I think you nicely presented what to look for. I would call the next managing orbital cellulitis in children, Dr. Varipokal Anjur Chandran.
A very good afternoon to all of you. At the outset, I would like to thank Laila Madam for giving me such an opportunity to speak amongst such august speakers. So today I'll be talking about one of the emergencies in ophthalmology. You can see the images of two children in this with almost similar presentation, but the focus today would be on orbital cellulitis in children. This is one of the most common causes of acute proptosis in children. I'll be taking you through this today. So what is orbital cellulitis basically? It is the infection. It's an infective process involving the lid and the orbital tissues. The simple structure here, which is a fibrous septum, it separates the lid and from the orbital tissues. So based on this, broadly we can classify it into a preseptal cellulitis and orbital cellulitis. In order to understand the disease better, we need to know that most often, especially in children, it is a contiguous spread of infection from the adjacent ethmoid and the maxillary sinuses. So the reason being the presence of a thin walled lamina papricia, which separates the sinus and the orbit. You have valvulus orbital veins from the sinuses to the orbits which carry the toxins, and also anterior and posterior ethmoidal foramina which behave as conduits. Apart from this, you also have infections arising from the dental caries or other foci of infection elsewhere, leading to a hematogenous spread and presenting as orbital cellulitis. And often trauma is also seen to disrupt the orbital tissues, leading to an infection of the same. So the spectra of microorganisms are usually the gram-positive cocci, which are Staphylococcus species and streptococci. Earlier, Haemophilus influenza used to be a common pathogen, but with the advent of Haemophilus vaccination for children, now we have seen a decrease in these organisms. But one needs to be cautioned because this is known to cause meningitis, so we need to treat this and follow them up closely. A rarer entity would be a herpes simplex virus infection or mycotic infections. Like we saw earlier, there would be an infection from adjacent structures, history of trauma could be there, surgeries could be there. Usually the mother would or the parent would say that there is a sudden onset of painful prominence and swelling of the eyelids. Children most often would not notice double vision or defective vision, but older children would talk of the same. And if the child is found to be drowsy or has a fever or sudden visual loss, then it's an indication that it is probably progressing. On clinical examination, you have the classic signs of inflammation, which are rubor, calor, dolor, and tumor. And as it progresses into the orbital tissues, there will be an impaired visual acuity. You will start to see RAPD, that is indicating that the optic nerve is at compromise. Ocular movement restriction will be noted. There will be a proptosis, and due to the raised intraorbital pressure, often you can record very high IOPs. So if you are to see dystopia in a child or displacement of the globe, that means there is a probable accumulation of mucopurulent discharge there. And any overlying skin involvement in the, could be seen in necrotizing fasciitis or mucormycosis. And if there is exposure, definitely there would be corneal epithelial breakdown. Vision losses have been reported in cases of orbital cellulitis, which could be due to CRA or a central retinal artery occlusion. Numerous classifications are there, of which our favorite one is the Chandler's classification of orbital complications in acute sinusitis. Like we saw earlier, preseptal cellulitis, which means the infection of the anterior lamellar structures, which is the skin and the subcutaneous tissue, whereby the child on top has just as preseptal cellulitis. The child beneath has a lid abscess, which was located only predominantly in the preseptal region, and the child improved with an incision and drainage. So orbital cellulitis, this is when the orbital structures are involved. And here on doing a CT scan, you will be able to see that there is inflammation and edema of the orbital structures, such as the extraocular muscles, and you can also note an optic nerve compression in very severe cases. A subariosteal abscess. So this is the collection of mucopurulent collection between the periosteum and the orbit. It need not always be an abscess. There is also an entity called subperiosteal effusion, whereby there is just inflammation beneath the periosteum, and this will be treated once you treat the infection per se with antibiotics. Orbital abscess and cavernous sinus thrombosis is a very severe form, which since most of us work in purely eye setups, you may not come across this very easily because the children would be drowsy and they will be needing systemic care and stabilization. Role of imaging cannot be overemphasized, especially doing CT orbits, because it is a quick way of doing imaging in children. It helps image the orbit and the sinuses simultaneously, also talking to us about the bony integrity, and you can also locate the abscess. MRI orbit, due to the difficulty of performing this in children, usually reserve it for cases where you're suspecting an optic nerve compromise or a suspected brain abscess or cavernous sinus thrombosis or a vegetative foreign body or a fungal infection. So as ophthalmologists, we need to know both about the ocular as well as the systemic complication. Here are a few, and you can also note that it can result ultimately in blindness. Similarly, this infection can progress to an orbital abscess, and due to the proximity of the brain, it can lead to a brain abscess, and ultimately it can even result in death. As a routine, it's best to send for a complete blood workup along with ESR and blood cultures. Also, if you have an external source of injury and there is pus, you can send that also for culture and sensitivity. Renal function test, because we would be starting these patients on IV or oral antibiotics, and renal clearance needs to be good. I personally like to do liver function tests and glycemic levels also to have an idea as to if we have any undetected diseases. CRP is per se not for diagnosing, it's just to look for the improvement or progression of the disease. So coming to the management part, preseptal cellulitis, pretty much easy. You can give oral antibiotics and anti-inflammatory drugs on an outpatient basis, but beware, you need to always have children under close follow-up, because there are cases where the child can progress very quickly, or they will require admission, especially in those who appear toxic or with a known H influenza infection, or who are starting to worsen, or they do not show any signs of improving. Orbital cellulitis, without thinking, you have to always admit the patient. You have to send for the blood workup, as we saw earlier. Broad spectrum IV antibiotics are started, and these can be modified eventually based on the blood culture and sensitivity patterns. You need to rope in a pediatric infectious disease specialist. ENT consultation is not mandatory, but in children, since the most common cause is sinusitis, it's always better to get their opinion too. Vision, pupil and EOM monitoring, every 4th hourly strict monitoring is required, and you can also add topical antibiotics of your choice. So being ophthalmologists, we are a little far removed from our general practice of giving antibiotics, so we are always in a fix as to what antibiotic we need to start first. So since we are dealing with a gram-positive spectrum predominantly, broad spectrum penicillins and 3rd generation cephalosporins are preferred. And in this, if you have a case of orbital cellulitis, IV antibiotics for a minimum of 48 to 72 hours is required, during which you will also look for improvement. So if you see that there isn't necessary improvement, that means there could be probably an anaerobic infection also, and you can add drugs such as metronidazole, tinidazole, and also clindamycin. MRSA coverage is given in cases which are likely developing an orbital abscess or going in for cavernous sinus thrombosis. But the treatment does not stop with just IV antibiotics for 48 to 72 hours. Even if the patient is being discharged, the child needs to be on antibiotics, oral antibiotics, for at least 7 to 10 days. So this is a debate whether you need to give corticosteroids or not. So if you note the term cellulitis, itis means inflammation. So by giving antibiotics, you're basically covering only the infective process, but there is an inflammatory component also, which can increase the hospital admission time, and it also can lead to other morbidities or complications. So we regularly, the ENT specialist regularly gives corticosteroids for sinusitis, which shows that there will definitely be an improvement. In a review article by Liu et al., CRP was seen as a potential marker for standardization of steroid therapy. There is no standardized protocol as to how much to give, but in my practice, what I would like to give is, while the child is improving, after 48 hours, you can give IV steroids and look for improvement, and thereby discharge the child on oral steroids in a quick tapering dosage with 1 milligram per kilogram. And surgical indications are obviously when the patient fails to improve and when you can locate orbital abscess. Necrotizing fasciitis, you have to look for progressive skin ulcerations, and this can quickly progress to systemic toxicity, so prompt referral and treatment is required. So we were talking about subperiosteal abscess. Not all cases require drainage. So in patients who are 9 years and above, who have large size of SPA, non-medially or located ones, recurrent SPA or associated chronic sinusitis and anaerobic infections or dental infections, you need to go in for a surgical treatment. So mycotic orbital cellulitis is rare. It's mostly seen in immunocompromised patients. And a few masqueraders here. So this is a child who has who presented with a similar picture, but it turned out to be a case of orbital inflammatory disease, which is almost similar to this. This was a child of thyroid eye disease. It's a bilateral presentation, but it can also be unilateral. This particular child had a lymphangioma into which there was an acute bleed. He did well with bleomycin intralesionally and drainage. And this was a case where a child had a recurrent orbital cellulitis picture, basically due to a ruptured dermoid cyst. And also you can see it in malignancies such as rhabdomyosarcoma and retinoblastoma involving the orbits. So I would like to end on this note. Do not take any periocular infections in children lightly, because just like how they bring home very bad upper respiratory infections, similarly the lid infections also can turn to be fatal, leading to orbital cellulitis. Thank you.
Thank you, Dr. Anju, for that wonderful coverage of orbital cellulitis. Now I call upon Dr. Sujit Nayanar, who is a senior cornea consultant in Calicut, Kerala. Though not very commonly seen, this is a problem, acute eye drops, which need immediate attention.
A very good afternoon. Thank you, madam, for giving me this opportunity. As part of this IC, I will be talking on the management of acute corneal eye drops in a child. Acute corneal eye drops in a child is nothing different from that of an adult. The management, diagnosis and all is almost the same, except for some special mention about certain things in the child, which we will be covering up in this particular talk. So understanding the condition, we all know that it's a break in the descemet membrane that is causing an aqueous humor influx into the stroma, causing an acute stromal edema. Stromal, as well as all the layers of the cornea, goes into an edematous status. So most commonly, once we see this, the diagnosis that comes to our mind is an ectatic corneal disorder, most commonly keratoconus. But when you look at the prevalence, the ectasia is the eye drops is more common in PMD as well as the keratoglobus rather than in a keratoconus. But when we consider a similar condition in a child, the only condition we can think of is keratoconus rather than the other conditions which are not very common in this particular age group. So is keratoconus that common in a first decade of life? The rare cases have been presented as early as 5 years, where the child is presented with an acute eye drops. So when you see a child with acute eye drops, keratoconus may not be the first condition in a very less age, like age of 5 years. Keratoconus may not be the first condition that comes to your mind. There has been other cases that has been reported, like you can see in a unilateral acute eye drops in a child with bilateral microcornea also. So we have to think of other conditions, and very importantly, don't miss the conditions such as the primary infantile glaucoma or a congenital glaucoma that can present later with the acute eye drops due to break in the descemet membrane. And also other conditions where has been reported where there is an infectious keratitis leading to acute eye drops, a forceps injury with descemet stay presenting as late as 5 years with acute eye drops. So there must be something that is causing or triggering this descemet breaks in a higher age group in a congenital condition. So we have to look into the conditions, what are the actual triggering factors or the risk factors that is causing this descemet breaks and leading to an acute eye drops. So certain conditions have been isolated, and In eye, the most common thing is this steep keratometry, thin cornea, steep keratometry, and elevated intraocular pressures. In susceptible individuals like atopic disease with heavy eye rubbing, especially in patients with learning disabilities, mental retardation, and Down syndrome. Very commonly seen in Down syndrome, I think whatever cases I have seen, 90% of the acute eye drops in a child is in a Down syndrome. So what are the histopathological changes happening here? Most commonly we think of a Descemet break and the influx of the aqueous humor into the stroma, but there are multiple conditions, multiple levels of histopathological changes, starting from the apical thinning of the epithelial as well as the stromal layers, basement membrane breaks, influx of the fluid into the stroma causing stromal fluid pockets, DM break, rolling of the DM, and loose posterior stromal layer, which is also identified as a risk factor for DM breaks and acute corneal eye drops. So diagnosis is mainly clinical. Of course, anterior segment OCT has got a big role in management, the current management of acute eye drops. So clinically, it's quite easy. It's acute or a subacute onset of a swollen edematous cornea. It can present as a localized area of corneal edema or a total cornea that is very badly swollen. Both these cases which I am presenting here is my own cases. Both are mentally retarded or Down syndrome patients. So there has been clinical grading of the corneal edema in a clinical in a acute eye drops based upon the amount, the size of the corneal edema, less than 3 millimeters, 3 to 5 millimeters, or more than 5 millimeters. Normally, symptom-wise, it presents with acute pain and diminution of vision. But sometimes, if it is a subacute presentation, the pain may not be a classical feature, especially in patients with Down syndrome. I don't know whether it's because they don't perceive the pain or they don't express the pain. And because of the, if it is a very early presentation and you suspect something other than keratoconus, don't forget to look the other eye for a clue on the etiology, what could have caused this. AIOS2025-IC117, there is a classic paper from LVP that shows 3 different types of changes in the Descemet membrane, and that is seen in acute eye drops. DM detachment with breaks and rolled edges, with breaks and flat edges, and sometimes even DM detachment without breaks. So that is against a thought that how it can happen without DM breaks. So it is explained that it may be a self-seed small breaks which may not be identified by AIOS-OCT. Why do you want to do an AIOS-OCT in a very clear clinically identified condition? It's to confirm your diagnosis, to have a clinical pictorial documentation of the condition, to locate the defect, in planning the management, monitoring the progress, and in prognosticating. How can you prognosticate? It has been clearly told in that paper that the size of the DM break, the depth of the DM detachment, and the corneal edema thickness, these 3 critical factors can be used to clearly identify how much time it may take to take that edema to subside. They have got it is seen that age and gender doesn't have any effect on the final result, and the C3F8 has shown to decrease the edema by at least 3 weeks. The depth of DM detachment, the more the depth, longer the edema period, the more the size of the DM break, the longer the edema period. So as per this equation, you can actually identify how much weeks it may take. And also in the resolution part, you can look at the DM detachment, and the healing phase can be monitored and prognosticated. So the management is either conservative or surgical. The ultimate aim of the management is to control the symptoms, help early resolution of the edema, prevention of potential complications, and the formation of a decent scar. Complications by meaning complications, I say the neovascularization should be prevented, which can happen in a very long persisting cases of acute eye drops. Infection is a possibility, perforation is a possibility in a very thin cornea, and scarring. Scarring is the ultimate thing which we want, but a decent scar. So the natural course is like the DM reattaches, the gap closes by new basement membrane formation, the endothelium migrates, the fluid pockets gets absorbed, the scarring results, and cornea flattens. But overall, the time period it may take is up to 3 to 4 months. It's a quite long period. The conservative approach, we try to give the symptomatic relief to the patient by giving cycloplegics, hypertonic agents, soothing effect by lubricants, lower IOP by anti-glaucoma agents, prevent neovascularization by giving short course of topical corticosteroids, prevent infection by antibiotics, and sometimes bandage contact lens. But surgically, we plan to do surgical intervention when we want an early result or when we want the edema to resolve faster, basically to prevent complications. So this paper from RPC shows that the surgical gives a flow chart on how to manage an acute hydrops in a surgical way. The first is to seal, and first and most easily or most popularly done is to seal the DM tear with a tamponade, gas tamponade, air or a gas tamponade. The gas is either SF6 or C3F8. All has been very successfully documented to help in a faster healing by sealing the gap and reattaching the DM and preventing the fluid ingress. But obviously with the risk of having a IOP rise and malignant glaucomas has been repeated. In the case of children, it is very difficult to maintain the supine position and it may need repeat injection under repeat GA. So that is one disadvantage, especially while considering in children. And in AIR and SF6, it has been shown that the need for repeat injections are higher, whereas in C3F8 it is not so, but definitely the pupillary block glaucoma risk is as high as 16 to 20% in cases where the C3F8 has been used. And there has been reports of malignant glaucoma, Uret-Zivalier syndrome, and non-resolution of an acute hydrops after a gas injection because the gas itself went into that air pocket and it remained in the stroma, preventing the absorption of the edema. So the next important method surgically is by using the compression sutures. It's as shown in the video, the defect is isolated and perpendicular corneal sutures are applied across that DM defect. It helps in closing the gap, reattaching the DM or approximating the DM edges more easily, which in effect gives stops the ingress of the fluids, squeeze the fluid pockets, helps in faster absorption of the fluid. This can be done with or without the gas tamponade. Here I have put the air bubble not as a gas tamponade or as a tamponating effect. It is only to identify the depth. So this can be done with the full thickness as well as a partial thickness sutures. This is shown to be very effective, and both these cases healed in almost 1 month. That very aggressive severe edema settled in almost 1 month to a decent scar. In some cases, you may not be able to identify the exact area of DM tear in very severe cases. In such cases, you put crisscross incisions, crisscross sutures across the cornea, which is also shown to be a very effective method. And this paper shows that there is no need for actual full thickness sutures. A partial thickness sutures without desmetopexy also gives good results, which is very ideal condition for children. This is just for a namesake because this is not very ideal surgery advocated in children. This is to replace that DM with a very small DM patch, a mini DMEC or a mini DSEC, which can be done or tried in adult cases, but it's very difficult to follow up such cases in a children. Similarly, Susan Jacob et al. Have shown the role of pre-desmetic DALC also to remove the anterior edematous stromal cornea. Ideally not a very good scenario to treat in a children. So the challenges in children mainly is to difficulty in the proper assessment, getting a good clinical photograph or an AIOS-OCT, identifying the exact location of the DM tear. The cases presenting early may go into a risk of amblyopia if you wait for a spontaneous resolution. So we go for an early intervention. The need for repeat GA is one risk factor. And risk of intracameral tamponade, though it is very effective, the position maintaining and IOP monitoring may be a challenge in children. So to summarize, in children specifically, we should not miss uncommon etiology like primary infantile glaucoma. Early intervention is always advocated. We have to prevent complication, especially corneal neovascularization, because in such cases the later treatment becomes more complicated. Compression sutures, preferably partial thickness without tamponade, seems to be the best first line of management, especially in the children. Aim for faster resolution and settling with a decent scar should be the aim, and visual rehabilitation should be based on the amount of scar. Even a contact lens treatment would be very useful after the eye drops, since the cornea flattens after the eye drops healing, and risk factor management should also be considered. Thank you very much for this opportunity.
Thank you. Thank you, Dr. Sujit, for that wonderful talk on hydrops, varied situations in hydrops. Thank you. Any questions? So we had covered most of the situations where children present with an acquired problem. So thank you all for the patient hearing. Can we have a photo?